Good morning. Okay, let's start. I'm talking on acute disseminated encephalomyelitis, or as we say commonly, ADEM. Acute disseminated encephalomyelitis is a mouthful, so I'll keep it at ADEM. It's usually a monophasic illness that affects the brain and spinal cord, typically after a viral, febrile illness. It's also been described after bacterial and parasitic infections as well. It's commonly in children, but adults encounter it from time to time, and there have been a lot of reports in adults as well. The pathogenesis is thought to be multifocal inflammation associated with demyelination related to an autoimmune phenomenon. On pathology, we see perivenous invasion of lymphocytes and monocytes associated with demyelination. So what causes ADEM? Well, a review from Tannenbaum Neurology, she found that 35% of the time that nonspecific URI symptoms are encountered prior to making a diagnosis. And we see here 26% no preceding infections were found in her series. And vaccination is a third, and 12%. We used to see this more after vaccinations before. So the original disorder was named post-viral exanthem encephalomyelitis following a measles infection, typically 1 to 2 weeks afterwards. It always had a very poor outcome, and children usually died. In some cases, we can refer to ADEM as post-vaccine encephalomyelitis as well. So the lesions in ADEM predominantly affect the white matter of both the brain and the spinal cord, and there are multiple lesions. And areas of demyelination are also seen and described in the cerebral cortex, thalamus, hypothalamus, and basal ganglion, the deep gray matter. On neuropathological examination, there's a limited extent of demyelination when and that's a way that you can help distinguish between ADEM and MS. However, histological features of both may certainly overlap. So, how do patients present to the hospital? What are their symptoms at the time they come into the emergency room? There have been several reviews, but they've all been largely retrospective and observational studies. All these reviews had good number of patients that who underwent a detailed workup. So let's review some of these reviews. I just quoted a few studies here, and we can see the top 3 or 4 diagnoses is headaches and fever. Altered mental status, encephalopathy, impaired consciousness have also been described early as a manifestation. What else can we see? Well, these reviews have also mentioned seizures, visual impairment, bilateral optic neuritis, and many children presented with had a polysymptomatic presentation that's more than one symptoms at the time of diagnosis. So onset to peak deficit is usually less than 24 hours, but some investigators have found that the peak deficit can be found up to 30 days. And recurrence has been reported by several authors, and I'm going to talk about this a little bit. So the incidence of ADEM is 0.4 per 100,000, with a median age of 6.5 years. There's a slight male predominance, and recovery is generally good. Time to recovery from the neurological illness is deficits is anywhere from a month to 6 months. So before we label a child with ADEM, we have to be really vigilant about other CNS pathologies, such as acute antiphospholipid antibody syndrome, vasculitis from collagen vascular diseases, neoplasias or tumors, neurosarcoidosis, another inflammatory condition of the CNS, mitochondrial encephalopathies, dysmyelinating syndromes, and of course, MS. So cerebral spinal fluid is definitely an investigation that's done on anyone that comes in with suspected ADEM. So we can find a variety of CSF findings, including mild pleocytosis with a lymphocytic predominance, mild protein elevation. Oligoclonal bands have been reported, but they are not common. So I think the highest oligoclonal band rate in a study was about 6 in a very large case series. And oftentimes CSF can be normal, so just because it's normal, it doesn't rule out the diagnosis. So MRI features are plenty, as I've listed. It's a whole laundry list. MRI is the diagnostic imaging of choice, and we see here predominantly affects the white matter, deep gray, like I mentioned before, the hypothalamus, the thalamus, basal ganglion, or both. Bilateral thalamic involvement have been reported by several authors, and the cortex has also been, which is gray matter, has also been involved. We can see vague enhancement. Hemorrhage is rare but can be found. The corpus callosum is usually spared. In MS, it's commonly involved. Periventricular lesions are not common in ADEM, but are very common in MS. And new lesions are typically not seen in follow-up imaging. That's when a child recovers and you get another MRI done. And new lesions should not be found in ADEM. And don't forget, the initial MRI may be normal as well. And it can affect the spinal cord. I didn't write the spinal cord features here. So Tannenbaum from Neurology 2002 classified her patients into 4 distinct groups according to neuroimaging features. Group A was the majority, 62%, multifocal, and these patients had multifocal small white matter lesions of demyelinations. Large confluent tumor-like lesions were found in Group B, and she found symmetrical bilateral thalamic involvement in Group C, and there were only 2 patients in her group that had hemorrhagic lesions. So you can see it's a variety. They can present with very different neuroimaging features. And here, this is the tumor-like lesions that people with Group B had. This is from Tannenbaum's review. So it looks pretty scary. And so you can see deep gray matter, deep gray nuclei involved here. I circled it for you. And this sort of compares ADEM to MS. We can see in ADEM the cortex involved, the deep gray matter involvement. And here in MS, we see periventricular lesions that are very common. And these are elliptical or ovoid and perpendicular to the ventricle. That's pretty characteristic of an MS brain. So how do we treat these patients? IV therapy, steroids, methylprednisolone is the treatment of choice. 20 to 30 milligrams is what is commonly used, but some authors have used 10 to 20 milligrams as well. And this is followed by a prolonged oral taper of prednisone. Dexamethasone can also be substituted if necessary. IVIG has been given for those who don't respond very well to steroids, and even plasmapheresis in fulminant ADEM, and those who require ICU admission who have hemorrhagic lesions. These patients can be tried on with plasmapheresis. So what's the outcome in these children? It's usually very good, with complete or near complete recovery found in 90%, 89, 71, and 83% from these various studies, just to name a few. Some children are left with some residual disabilities. ICU admission and ventilator support may be necessary, and death is not common, but it can occur. And relapses can occur, and of course, it's not commonly encountered. So let's talk about relapsing or recurrent ADEM. Several reports have been described. Several authors have found various number of patients who have this relapsing form of ADEM. We have a few patients ourselves that we follow with this condition. So a few questions come to mind. Is this MS? How do we treat it? What is the long-term clinical outcome of these patients? And the answer is, I'm not sure. So how do we define relapsing ADEM? It's 2 or more separate acute episodes that differ in clinical presentations. And another question found in the literature is this condition a separate clinical syndrome or it's part of the MS spectrum? Another term that describes relapsing ADEM you'll probably hear or you'll probably read in the literature is multiphasic disseminated encephalomyelitis, MDEM, and this is used by a few authors. So let's see how many people in these studies have actually relapsed. Well, we see 4, we see 8, 10%, but the highest is reported by Anlar with 33% so far in the literature. So how do we treat these relapses? Well, the same as that for monophasic ADEM, IV steroids. We may consider standard immunomodulatory therapies such as the ABCR drugs used to treat multiple sclerosis, but we don't know what it does for this condition, and there's really no evidence available at this time. So how can we distinguish relapsing ADEM from MS? Well, we can look at the first the age of onset of the first clinical symptom. Usually ADEM children are younger. And symptoms at presentation, do they have a polysymptomatic presentation, headaches, fever? That goes more along with ADEM rather than MS. And possibly CSF parameters such as oligoclonal bands, and that would sort of give us a favor MS. And possibly MRI features acutely. Imaging during convalescence, during recovery. In patients with ADEM, we should not see new lesions. Family history of MS can certainly help. And more sophisticated neuroimaging modalities have been reported with magnetic resonance spectroscopy and diffuser tensor imaging. DTI is actually been reported with ADEM, and it evaluates white matter changes that are not otherwise seen on conventional MRI, white matter abnormalities that are not seen on conventional MRI. And ADEM patients are reported to have normal white matter compared to those of MS with this imaging modality. So it may hold some place, but it's still in the research stage. Okay, in summary, ADEM appears acutely. It's usually found in children less than 11. It's typically monophasic, but as I've stated, relapses have been reported. Encephalopathy, which is altered mental status, fevers, headaches are the initial symptoms at presentation in a lot of children. It can affect, it can affect both white matter and gray matter. The recovery is generally good, and MRI may normalize, should have put may normalize during convalescence. So I have a case here, a brief case of a patient that we and some pediatric neurologists are following. I just thought I would share it with all of you. This is an 11-year-old Caucasian girl with recurrent episodes of weakness associated with headache and altered mentation. Seizures were associated with some of these relapses. She began having, her initial symptom actually was at the age of 6, and she has a family history of lupus. CSF was obtained initially and on subsequent visits to subsequent relapses, and oligoclonal bands IgG index were negative. She was then started on Copaxone 2 years later after initial presentation, thinking maybe this will help her relapses, but she continued to have them. She had been doing well in school all along. After I'd seen her, we switched her to Rebif, and then it's hardly been a year. It's only been actually 7 months. We think she's responded, but time is really short. So this was her I think her second MRI scan. You can see how extensive these lesions are. They're even periventricular, but look at the white matter. It's huge. So this was another relapse. During another relapse, you can see extensive white matter involvement here. I don't have her recent MRI scan because we have a different system in our hospital, and I wasn't able to cut and paste, but then she just had a few periventricular lesions, so it was not dramatic, and most of those lesions had resolved. And so, again, we don't really know how to treat these patients, but we're treating them as multiple sclerosis, and only time will tell to see whether they respond to this form of therapy or not. Thank you, and this concludes my presentation.